So we begin with question number 137 of GT 182. So question number 137 was, features of scurvy in children include bleeding from gums, tibial edema, costochondral junctions become angular, windswept hip deformity in older children with cerebral palsy, and splaying and cupping of metaphysis. So the correct option to this question are A, bleeding from gums, tibial edema, and costochondral junctions becoming angular. So these are the three correct options to this question. So what we know about vitamin C? Vitamin C, or ascorbic acid, as it is also known, is a water-soluble vitamin. Like we know that vitamins can be divided into two groups, water-soluble and fat-soluble, and the water-soluble vitamins are vitamin B and vitamin C. So here we will be discussing about vitamin C or ascorbic acid. So this is a water-soluble vitamin. And what are the main functions of vitamin C? It acts as a strong reducing agent. Reducing agent for the normal functions of leukocytes, fibroblasts and osteoblasts. It also affects the immune response. It has a role to play in detoxification as well. And it also plays a very important role in collagen synthesis and wound healing. So what are the important functions of vitamin C? As we see, it acts as a strong reducing agent in the normal function of leukocytes, fibroblasts and osteoblasts. It affects the immune response of the body. It helps in detoxification, and it also helps in collagen synthesis and wound healing. So what are the clinical manifestations in case of vitamin C deficiency? First, vitamin C deficiency mainly manifests in children between 16 to 24 months of age, babies or infants who are predominantly breastfed or are on a milk-based diet, because milk is deficient in vitamin C. So all those babies who are on a milk-based diet will manifest deficiency of vitamin C. The initial symptoms may be non-specific, and they may include irritability, anorexia, not taking interest in surroundings. And apart from the non-specific symptoms, there can be other symptoms as well. And important amongst these are, you can see once teeth have erupted, an important manifestation of vitamin C is bleeding gums, swollen gums. These are mainly seen once teeth have erupted. Apart from that, there are children can manifest as pseudo-paralysis. Now, what do you mean by pseudo-paralysis? That there is no true paralysis, but the baby remains in a state like of not moving his limbs, and that mainly results because of bleeding under the bones, which causes pain and tenderness, and hence the baby does not like to move his limbs to avoid the pain and tenderness, and hence this condition is called pseudo-paralysis. So they can also be swollen joints. There can be bleeding in the skin, which can manifest as petechiae or purpura. And severe vitamin C deficiency may result in degeneration of skeletal muscle as well. They can also result in cardiac hypertrophy or in bone marrow depletion and in adrenal atrophy as well. So how do you diagnose vitamin C deficiency? Well, for diagnosis, you need a proper history, where the child may be predisposed to vitamin C deficiency. For example, like we have discussed, a child who is on milk-based diet may be predisposed to vitamin C deficiency. Along with that, the characteristic clinical features that we have just now discussed. And on laboratory findings, plasma and serum vitamin C concentrations may be reduced. Serum vitamin C concentrations may be reduced. And apart from that, another important mode by which you can diagnose vitamin C deficiency is radiology. So what happens in vitamin C deficiency? We can see the signs in the long bones, and while in rickets, it's basically the wrist joint where these changes can be seen. In vitamin C, the knee joint is primarily the site where these changes can be seen. So you can order a X-ray of the knee joint and you can see the changes that occur in the long bones. So I will just tell you the important changes that one can see on the X-ray, especially in the long bones. For example, this is the femur, and you can see that at the ends, you can see this white line of wrinkle. This is a dense line. This is called the white line of wrinkle. And the epiphysis, there might be a ring of calcification around the epiphysis. This is called the the Wimberger's sign. So these are the two important radiological signs which are seen in vitamin C deficiency. So for therapy, how do you treat vitamin C deficiency? For therapy, you can administer 100 to 200 milligram of either oral or parenteral vitamin C, and you can see significant improvement in the child's condition. So this is what we had to talk about vitamin C deficiency or scurvy. Now we come on to question number 138. And question number 138 talks about the poor prognostic factors in bacterial meningitis in children include age less than 6 months, seizures occurring more than 4 days into the therapy, neck rigidity, focal neurological deficits, and high concentration of bacteria in the CSF. So the correct answer to these questions include A, age less than 6 months, seizures occurring more than 4 days after therapy, after treatment has already been started, and in case seizures were not present initially and they occur of almost 4 days after therapy has begun. Focal neurological deficits, and high concentration of bacteria in the CSF. So these are the poor prognostic features in a case of meningitis. So what we know about meningitis? Well, in meningitis, there is inflammation of the meninges, which are the covering of the brain, and it can happen because of infection in the bloodstream. It can also occur due to infection which has occurred in the contagious organs. For example, if there is fracture of cribriform plate, or if there is already an infection in the mastoiditis, in the mastoids, leading to mastoiditis, that can the infection can extend and can infect the meninges of the brain and cause meningitis. So at different age groups, different organisms are responsible for causing meningitis. So in a neonate, the most common organisms include E. coli, strep pneumoniae, and Salmonella species. These are the common organisms that cause meningitis in the neonatal period. And in children between 3 months to 3 years of age, the common organisms include H. influenzae, strep pneumoniae again, and Neisseria meningitidis. While in older children, that is beyond 3 years, the common organisms include strep pneumoniae and Neisseria meningitidis. But now, because in the national schedule in India, we have included vaccines against H. influenzae and strep pneumoniae, so the incidence of meningitis because of these organisms is reducing. And it has been seen that with appropriate therapy and diagnosis, the mortality and the morbidity because of meningitis is also reducing. So now, mortality because of bacterial meningitis has reduced to less than 10%. However, we should also know that severe developmental sequelae are known to occur in children who have suffered from meningitis. And what can these be? These can include sensory neural hearing loss, which can result due to cochlear infection or direct infection of the auditory nerve. There can be mental retardation. There can be recurrent seizures. There can be defects with language. There can either be language delay. There can be visual problems. And at the same time, there can be behavioral problems as well. So a child who has had meningitis can have any of these problems. And what are the complications that can occur while a child is undergoing treatment for bacterial meningitis? So a child who was probably initially responding but starts to have fever again while in the hospital, that can be because of either a subdural effusion or a subdural empyema. This may also manifest as signs of raised intracranial pressure. At the same time, there can be ventriculitis, by which we mean infection of the ventricles. There can be development of brain abscess or hydrocephalus, which basically results because of the deposition of exudates in the pathway, in the CSF pathway. So that can result in hydrocephalus. All these CNS manifestations should be suspected if a child who was initially responding starts to have fever again or starts deteriorating. Apart from the complications, the later long-term sequelae can also include hemiplegia, if there was any focal lesion in the brain. There can be aphasia. There can be hemianopsia. There can be blindness and mental retardation, as we have already discussed. Other systemic complications can also include status epilepticus, myocarditis, and syndrome of inappropriate ADH secretion. So now we come on to question number 139. And question number 139 was, Question number 139 was, short stature are found in all except malnutrition, emotional deprivation, congenital heart disease, Klinefelter syndrome, and hypothyroidism. So, the correct answer to question number 135 is D, Klinefelter's syndrome. Why is this the wrong answer? Because in Klinefelter's syndrome, you find tall stature and not short stature. And this is a genetic syndrome which is characterized by XXY chromosomal anomaly. So, how do you define short stature? Well, the American Academy of Endocrinologists defines short stature as a height which is less than 2 standard deviations below the mean for the particular age and gender, while short stature can also be defined as a height which is less than the 3rd percentile for the general population. So both these are definitions of short stature. Now, short stature can be classified as either physiological or pathological. So, what are the physiological causes of short stature? There are 2 main causes of physiological short stature. These are familial short stature and constitutional. So what do you mean by familial short stature? In familial short stature, both the parents will also be short. So the child will develop a height which is in accordance with the genetic potential of his parents. So if his parents are short, the child is also likely to be short in future. So that is a familial short stature. While in constitutional short stature, it is seen that these children are late bloomers or that they will gain their height little later in life. In such children, we can get a history that the parents were also attained their puberty at a later age, and hence they also had attained their height a little later than their peers. So these are the two causes of physiological short stature. Now we come on to pathological short stature. Now pathological short stature can result due to various causes. These can include psychosocial dwarfism, or it is also known as maternal deprivation syndrome, where the child cannot gain height because of the stress that he is in. And this condition actually mimics hypopituitarism, where it has been seen that the levels of the insulin growth factor, which is the mediator of the growth hormone, is reduced. So the concentrations of insulin-like growth factor are reduced in children who have psychosocial short stature. And it has been seen that once these children are removed from a stressful environment, they tend to gain their height. So apart from that, other causes of short stature include undernutrition or malnutrition. It can also result due to chronic systemic illnesses. So the common systemic illnesses include, for example, in the renal system, it can include chronic kidney disease. It can result due to RTAs. In the GI system, short stature can be seen due to celiac disease or any other condition which is causing malabsorption. It can also result due to CLDs or chronic liver disease. In the cardiovascular system, it can result due to congenital heart diseases, both cyanotic as well as acyanotic. It can also, in the respiratory system, it can result due to cystic fibrosis. And it can also result due to bronchiectasis. So these causes are of chronic systemic illnesses. Apart from that, there can be endocrine causes of short stature as well. And these include, the endocrine causes of short stature include growth hormone deficiency. It can include hypothyroidism. It can be due to children who are born SGAs, and it can also result due to skeletal dysplasias. Skeletal dysplasias may also cause short stature. Apart from that, there can be certain genetic syndromes as well. For example, the Turner's syndrome and Down's syndrome. They all can cause short stature. So these are the main causes of short stature that we have discussed. So now we come on to question number 140. And question number 140 was, a 9-month-old girl is presented to the emergency with perrectal bleed, vomiting, mass and colicky pain in the right lumbar region with masked liver dullness. She is in a state of a shock-like condition, and management should include, so the options that you had were barium enema, saline reduction, give oxygen, nasogastric tube, and IV fluids. So in this question, the diagnosis is in this question we are talking about intuitusception. Now, what is a intuitusception? It is a process where, or a condition where, a segment of the intestine invaginates into the adjoining intestinal lumen, causing bowel obstruction. So this is what intuitusception means. I will just show you a diagram in which it will be slightly more clear. So in intuitusception, a segment of intestine invaginates into the adjoining intestinal lumen, causing bowel obstruction. So what does it mean? It means like this, like if you see a diagram, when the bowel will invaginate, this is how it will, this is just a diagrammatic representation and how a bowel lumen can invaginate into the other intestine, and this will result in bowel obstruction. What happens is when this portion of the bowel is invaginating into the other segment, the adjoining mesentery will also go along with it. This will cause compression of the vessels as well as the lymphatics, causing gangrene of the involved segment. So this is what the pathophysiology happens in intuitusception. It is most common in children who are between 6 months to 18 months of age. And the most common variety is the ileocolic intuitusception. The etiology of intuitusception can be either idiopathic. It can be either idiopathic, where no cause can be ascertained for intuitusception, or it can be secondary, in which an intraluminal pathology can be seen. For example, it could be a polyp, it could be any growth, or it could be a submucosal masses which act as lead points. It could be an intraluminal pathology like polyps or growths or submucosal masses. So the most common site of idiopathic variety is the ileocecal region. And the most common lead point is a hypertrophied Peyer's patch. A hypertrophied Peyer's patch acts as a lead point. And this hypertrophy may have resulted due to change in the bacterial flora during weaning or during gastrointestinal infections. So how will you make the diagnosis? Diagnosis can be made on the basis of a good history, which includes that of severe colicky pain, in which there are paroxysms of pain. In between of these paroxysms, the child will appear normal and be playful. There could be vomiting, which is initially non-bilious, but later on can become bilious. And characteristically, there are presence of red currant jelly stools. This is characteristic of intuitusception. Red currant jelly stools are characteristic. Usually when you examine such patients, there may not be any significant finding, but often you can find a sausage-shaped mass, which is usually present in the right upper abdomen. But it is not necessary that this will be formed, and the direction of this mass is usually cephalocaudal. A sausage-shaped mass in the right upper abdomen. The direction of which is cephalocaudal. What are the investigations that can be done to diagnose intuitusception? So on X-ray abdomen is usually not relied upon, but sometimes you can see a density in the region where the intuitusception has occurred. So an X-ray abdomen is usually not relied upon, but you can always get it done. X-ray abdomen is usually not relied upon. Apart from that, you can also get a ultrasound abdomen, in which you can get a pseudo kidney sign or a bowel in bowel sign. A pseudo kidney sign or a bowel in bowel sign. So once you have diagnosed intuitusception, the important part is of treatment. So such a child has to be kept NPO. In the recent times, there have been some new advances as well. Initially, a laparotomy was essential to manage a patient of intuitusception, but in these days, there are certain options of non-operative reduction that are also available. So for non-operative reduction, you can use either saline or other water-soluble contrast media, or air can also be used to cause non-operative reduction of the intuitusception. But we have to keep in mind that peritonitis or perforation are absolute contraindications of non-operative reduction. So if it is suspected that the child has already developed peritonitis, then surgical option is the mode of choice for treatment. However, if there is no perforation or peritonitis, non-operative reduction can be used. So now we come on to question number 141, and it talks about true about breastfeeding is best for both preterm and term, 50% energy from proteins, promotes lactobacillus growth in bowel, predisposed to necrotizing enterocolitis, and decreases allergic disorders. So for question number 141, question number 141, it talks about breastfeeding. So the correct answer to this question is best for both terms and preterms. promotes lactobacillus growth in bowel. And decreases the risk of allergic disorders. So, as we all know that exclusive breastfeeding is recommended up till 6 months of age. So, for 6 months, mother should give only breast milk and nothing else. So, what are the advantages of breast milk? First, it reduces the risk of allergic disorders in the baby in later life. Even children who are breastfed are found to have less risk of developing allergic disorders like allergic rhinitis and asthma in later life. Apart from that, we know that it is clean and it is free from the risk of contamination. It is free from risk of contamination. Babies who are breastfed will also have a less risk of developing necrotizing enterocolitis. In fact, babies who develop necrotizing enterocolitis are most often formula fed. Babies who are breastfed are found to have a higher IQ in later life, and their mathematical abilities are found to be better. And it has also been seen that breast milk, though having lower concentration of iron, its bioavailability is higher because of the presence of lactoferrin. Apart from that, breast milk also contains certain immunoglobulins and anti-infective factors which will help in boosting the immunity of the neonate. So these are the advantages of breastfeeding. So, and a mother can secrete up to 450 to 600 ml of milk daily, which will have a protein content of almost 1.1 gram of proteins per 100 ml. Per 100 ml. And the energy content of breast milk is close to 70 calories per 100 ml. So these are the reasons that we should promote breastfeeding in neonates, especially up till 6 months of age. So now we come on to question number 142. And question number 142 is, true about TOF is recurrent chest infections, clubbing of feet, squatting, cyanotic spells, CHF not occur. So the correct answer to this question is clubbing of feet. We know that tetralogy of Fallot is a cyanotic heart disease with reduced pulmonary blood flow and which has clubbing of both hands and feet. So the correct options are clubbing of feet, squatting episodes, cyanotic spells, and CHF not occur. So now, what is TOF? TOF stands for tetralogy of Fallot. So what are the main components of this tetralogy? There are 4 main components of this tetralogy, and these include severe right ventricle outflow obstruction, there is a large non-restrictive VSD. There is a large non-restrictive VSD. There is a aorta that overrides the VSD. Aorta overriding the and there is right ventricular hypertrophy. So these are the four components of tetralogy of Fallot. There is severe right ventricular outflow obstruction, there is a large non-restrictive VSD, the aorta overriding the VSD, and there is right ventricular hypertrophy. So TOF is a cyanotic heart disease with reduced pulmonary blood flow. As we see that there is pulmonary stenosis, so there is decreased pulmonary blood flow. So all the cyanotic heart diseases which have decreased pulmonary blood flow do not have recurrent chest infections. So the option that was given here in this question, true about TOF, recurrent chest infections, is out. A condition which is manifesting with decreased pulmonary blood flow will not manifest with recurrent chest infections. Instead, it will manifest with cyanotic spells or squatting episodes. So because tetralogy of Fallot has decreased pulmonary blood flow, there are episodes of cyanotic spells which usually occur after exertion or after the child cries vigorously, in which case the pulmonary stenosis becomes more severe and the flow across the pulmonary valve further reduces. In this situation, the child becomes even more cyanotic and sometimes may even lose consciousness. So, in TOF you see decreased pulmonary blood flow, you see cyanotic spells, and you should also know that TOF is the most common cyanotic disease which is encountered after 2 years of age. In fact, up till 75% of all cyanotic patients will be TOF. The clinical presentation of TOF will be determined by the severity of the right outflow obstruction. So the severity of the right ventricular outflow obstruction will determine the severity of TOF. Apart from cyanosis, there is increased erythrocytosis as well, which occurs because of hypoxia, which results due to the right to left shunt, which manifests as polycythemia. And another important feature of TOF being that CHF will never occur in TOF except in few conditions. And what are these exceptions? The exceptions are if the child has concomitant anemia, if there is concomitant infective endocarditis, or if the child has concomitant systemic hypertension, or if there is concomitant myocarditis, or if there is associated aortic regurgitation or tricuspid regurgitation. So these are the conditions where CHF may occur even in the presence of TOF, and these are anemia, infective endocarditis, systemic hypertension, myocarditis, and aortic or tricuspid regurgitation. The characteristic chest X-ray findings in case of TOF are a boot-shaped heart, which represents right ventricular hypertrophy. It is also called as Corin-Sabot. So this is a characteristic X-ray picture of tetralogy of Fallot. And the diagnosis can be confirmed by a echocardiography. So now we come on to question number 143. Question number 143 is, true about iron deficiency anemia in children and infancy is, iron absorbs from terminal ileum, cow milk contains less iron than human breast milk, Serum ferritin depletes first, decreased alertness and decreased red cell distribution width. So the correct answer to this question is question number 143. The correct options are serum ferritin depletes first, and decreased alertness. So, we know that the human breast milk provides almost 0.3 milligram per liter of iron, while the cow's milk has double this amount of iron. But the availability of iron from human breast milk is higher as compared to cow because of the presence of lactoferrin. Further, iron is absorbed from the proximal small intestine, taking help from variety of duodenal proteins. Pallor is the most important clinical manifestation of iron. Apart from that, it has been seen that decreased alertness also results due to iron deficiency anemia. Children who are deficient in iron may also show phagophagia or pica, which means abnormal tastes. These children will usually come with a history of either eating this chalk paint, or they may eat mud. So they have abnormal tastes, which is called phagophagia or pica. And if iron deficiency is severe and anemia is severe, child may even land up in congestive heart failure. So what are the lab findings that you will see in case of iron deficiency anemia? The important lab findings include serum ferritin, which reflects the iron stores in the body, which start reducing first. Apart from that, next, the serum iron levels will reduce. Serum iron levels will fall down and the total iron binding capacity of the serum will increase. Apart from that, when the RBCs will be seen, it will be seen that they are smaller and they are pale. So there will be microcytic as well as hypochromic. So RBCs in case of iron deficiency anemia will be microcytic and hypochromic. And the red cell distribution width, which is manifested by RDW, will be increased. So how do you treat iron deficiency anemia? You have to supplement with iron in a dose of 4 to 6 mg per kg per day. And how soon can the response to iron come? It can come within 12 to 24 hours. So what will be the response once iron therapy has been initiated? Well, that can be seen sometimes in less than 12 to 24 hours. And what can be the responses to iron therapy? Well, within 12 to 24 hours, because of the replacement of intracellular enzymes, the child's irritability will reduce and alertness will increase. So there is increased alertness and reduced irritability after iron therapy has been initiated because of the replenishment of iron enzymes. Then within 36 to 48 hours, a bone marrow response manifesting as erythroid hyperplasia will be manifested. A bone marrow response which can be seen in the form of erythroid hyperplasia will be seen within 48 hours of initiating appropriate iron therapy. And within 3 days, a reticulocyte response can be seen. And in 4 to 30 days, an increase in hemoglobin will manifest. An increase in HB levels can be seen, and over a period of 1 to 3 months, the stores of iron will be replenished. Replenishment of iron stores will take 1 to 3 months. So this is about iron deficiency anemia. Now we come on to question number 144. Question number 144 talks about plantar calcaneal spur are not seen in Reuter's disease, scleroderma, rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. So now let us first see what is a calcaneal spur. Well, a calcaneal spur is a bony growth a bony outgrowth from the calcaneal tuberosity So what happens is, when the foot is exposed to constant stress, calcium starts depositing on the bottom of the heel, and though they may not cause any problem to the individual, but because of repeated stress, these deposits keep increasing and they form a bony outgrowth which can be detected only on an X-ray examination. These are very common in obese people, people who wear high-heeled shoes on constant basis, and even people who are flat-footed. Apart from that, they are also seen in certain inflammatory disorders as well. So they are commonly seen in obese people, people who are flat-footed, and people who constantly wear heels. And other inflammatory disorders where this can be seen include gout, can be seen in ankylosing spondylitis, and it can also be seen in Reuter's disease. Another important cause of calcaneal spur is plantar fasciitis. So these are the important causes of this bony outgrowth that occurs on the calcaneum, which results due to constant stress over the foot bone. So now we come on to our next question, which is question number 145, and it talks about a child can swap objects from one hand to another at 2 to 3 months, 5 to 6 months, 6 to 12 months, 12 to 18 months, or 20 to 24 months. So the correct answer to this question is 5 to 6 months. A child will be able to transfer objects from one hand to another or swap objects by around 5 to 6 months. So what are the important gross motor milestones that we need to know? These can include holding the head upright while sitting, which is seen close to 2 months. Pull to sit with no head lag is seen close to 3 months. Bringing hands together in midline is seen at around 3 months. Asymmetric tonic reflex gone or ATNR gone at 4 months. Sitting without support at around 6 months. Walking alone at around 12 to 13 months. And running at around 16 months. So these are the important milestones up till 2 years of age. So now we come on to question number 146. So question number 146 talks about a child can transfer object from one hand to another and is babbling will be able to say ma, ba, da, these are monosyllables, will show stranger anxiety, will reach out to objects with one hand, and D, imitates scribbling. So the correct answer to this question is, the correct options include say, ma, ba, da, these are monosyllables and not bisyllables. He will be showing stranger anxiety. He will refuse to go away from parents to strangers. So stranger anxiety. And he will reach out for objects with one hand. So this child who was able to transfer objects from one hand to another was close to 5 to 6 months, and at close to this age, the child will be able to use monosyllables saying ma, da, ba. He will be able to show stranger anxiety, and he will show a unidextrous approach and will reach out to objects with one hand. So now we come on to question number 147. And question number 147 is, skin changes in protein energy malnutrition may result due to zinc, essential fatty acids, vitamin A, or pyridoxine. So the answer to this question is zinc, essential fatty acids, and vitamin A. So zinc, essential fatty acids, and vitamin A all will cause skin changes that are seen in protein energy malnutrition. So the common skin changes that are seen in protein energy malnutrition may manifest in the form of xerosis. They can result in flaky paint dermatosis, they can also result in increased pigmentation. They can result in desquamation as well as dyspigmentation. Sometimes pigmentation may be confluent and may resemble flaky paint dermatosis, and the skin changes that result due to zinc deficiency may appear like burnt skin, and that is known as, if it is severe, it is known as acrodermatitis enteropathica. The skin changes due to zinc which are severe are known as acrodermatitis enteropathica. So now we come on to question number 148. Question number 148 is, true regarding classical tetralogy of Fallot is right to left shunt, left to right shunt, severe pulmonary valvular stenosis, subvalvular pulmonary stenosis may be severe, and VSD is small. So, question number 148, the options are A, right to left shunt, severe pulmonary valvular stenosis, subvalvular pulmonary stenosis. Subvalvular pulmonary stenosis may be severe. So these are the correct options. So these are the correct options: right to left shunt, severe pulmonary valvular stenosis, and subvalvular pulmonary stenosis may be severe. So though we have already discussed TOF, I will just briefly describe it again. Tetralogy of Fallot is the most common cyanotic heart disease in children over 2 years, accounting for almost 75% of these patients. In children less than 2 years. It is a cyanotic heart disease with decreased pulmonary blood flow, which means that there is pulmonary stenosis, and there can be either pulmonary valvular stenosis or there can be subvalvular pulmonary stenosis. Both of these can be a part of tetralogy of Fallot, and this is a condition manifesting as reduced pulmonary blood flow. So pulmonary stenosis. So apart from pulmonary stenosis, you also find overriding of aorta. Overriding of aorta. There is a large non-restrictive VSD. And there is right ventricular hypertrophy. The child may have both cyanosis as well as polycythemia, both resulting because of hypoxemia due to the right to left shunt. These children usually manifest with cyanotic spells, which manifest sometimes after crying or after exertion, when the pulmonary stenosis becomes severe and the blood flow across the pulmonary stenosis reduces even further. So these children manifest as with squatting episodes. Clubbing can be seen both in the hands as well as feet. The chest X-ray may show a boot-shaped heart. And usually CHF will not occur in tetralogy of Fallot except in case there is anemia, in case there is infective endocarditis, if there is systemic hypertension, if there is unassociated myocarditis, and if there is associated aortic regurgitation or tricuspid regurgitation. In the presence of these conditions, CHF can occur with tetralogy of Fallot. Otherwise, CHF is usually not seen in patients with tetralogy of Fallot. So now we come on to question number 149. So question number 149 talks about a 3-day-old boy with history of birth asphyxia is presenting with breathlessness and seizures. Most probable etiology is pyridoxine deficiency, neonatal tetanus, hypoglycemia, hypocalcemia, and intracranial bleeding. So the correct answer to this question is hypocalcemia. Hypocalcemia is the most probable cause of seizures in this child because it is an endocrinal disorder which occurs in children who are at high risk. These include children who have had perinatal asphyxia, or infants of diabetic mothers, and preterm infants all have reduced stores of calcium and can manifest with hypocalcemic seizures in the neonatal period. But in this case, we see that we have a 3-day-old boy who has a history of birth asphyxia. So this is the correct option because hypoglycemia can be ruled out because there is no history of whether the child was infant of diabetic mother or not. Neonatal tetanus usually does not manifest in the first 3 days of life, and intracranial bleeding is usually seen in preterm neonates, which may manifest as intraventricular hemorrhage. So in this child, the most probable cause of seizures is hypocalcemia. So if a child has developed hypocalcemia, needs to be treated with IV calcium in a dose of 140 milligram per kg. And they should also be supplemented with vitamin D. Pyridoxine deficiency is a very rare cause of seizures, and it should be suspected when all the other causes of seizures have been ruled out, and these seizures are difficult to control with the commonly used anticonvulsant drugs. In such scenarios, we suspect that the seizures may have resulted due to pyridoxine deficiency. Hypoglycemia is another metabolic cause of seizure, and it is most commonly seen in children of infant of diabetic mother, or they are seen in children born to diabetic mothers. It is defined with a level of blood sugar less than 30 milligram per deciliter, and onset is usually within 1 to 2 hours of age and is most often seen in children who are macrosomic. So children who are macrosomic born to diabetic mothers are more at risk of developing seizures due to hypoglycemia. So now we come on to question number 150. Question number 150 is, stalk bite lesion are seen in Sturge-Weber syndrome, Klippel-Feil syndrome, blue rubber bleb nevus syndrome, macular staining of infant, and craniofacial nevus. So the correct answer to this question is macular staining of infant. Macular staining of infant. Well, stalk bite is a common type of birthmark which is seen in newborns. They are mainly seen over the glabella, over the eyelids, and the nape of the neck. Generally, they will increase in intensity if the child is crying or if there are changes in the environmental temperature, and they usually go away by the age of 18 months. But in case they stay till the age of 13 years, they can be reduced by the use of laser therapy, especially for cosmetic purposes. Otherwise, they will not cause any harm to the person. If somebody wants to remove them because of cosmetic purposes, they can be reduced with laser therapy if they do not go away till 3 years of age. So now we come on to question number 151, and question number 151 is, all are correct statements about cerebral palsy in children except may be associated with birth asphyxia, low birth weight is a risk factor, it is a progressive motor disorder, seizures is common, mental retardation is commonly associated. So the correct answer to question number 151 is C. It is a progressive disorder. So this is a false statement about cerebral palsy. Cerebral palsy is a non-progressive disorder. Cerebral palsy is a non-progressive disorder that mainly results due to most of the time it results due to perinatal asphyxia or any perinatal injury that occurs especially in the motor areas of the brain, which affects the motor system. And apart from the motor system, it can have many other manifestations that we will just see. The different types of cerebral palsy include spastic, ataxic, dyskinetic, or mixed. So spastic CP is the most common type of cerebral palsy, and there can be multiple risk factors. For example, prematurity, low birth weight are independent risk factors for cerebral palsy. Low birth weight, preterm birth are risk factors for cerebral palsy. In term babies, if the mother has had prolonged leaking, or if the mother has been exposed to some infection during the labor or in the time period immediately prior to the labor, if she has had leaking PV for long periods, if she has had history of chorioamnionitis, then these babies will be predisposed to developing cerebral palsy. Apart from that, if a child has obstructed labor, if the duration of labor was too much prolonged, if there has been any signs of intrauterine hypoxia, all these can be a risk of cerebral palsy. In utero hypoxia, the prevalence of CP is high in preterm babies, particularly if their weight is less than 1000 grams. And this mainly results primarily due to intraventricular hemorrhage and periventricular leukomalacia. And dyskinetic CP is more common in children who develop neonatal jaundice or develop kernicterus. These children are more likely to develop extrapyramidal or dyskinetic form of cerebral palsy. Spastic quadriplegic CP is the most severe form of cerebral palsy, where both the upper limbs as well as the lower limbs are involved. And in spastic diplegia, the lower limbs are more involved as compared to the upper limbs. Apart from just the motor abnormalities, which may manifest as increased in tone and other movement disorders, these children may also have seizures, they may have vision abnormalities, they may also have hearing problems, they may also have feeding difficulties. They are at risk of aspirations because there is oromotor dysfunction. So they will have feeding problems. And managing these children will need a multidisciplinary approach where all these problems can be catered to at the same time. So now we come on to question number 152, and it talks about corticosteroids are useful in which of the following pediatrics disease. And the options are TB meningitis, endobronchial TB, spina ventosa, acute tuberculous pericardial effusion, and severe miliary tuberculosis. So the correct answer to this question is TB meningitis, endobronchial TB, and an acute tuberculous pericardial effusion. Usually steroids in tuberculosis are recommended when the host inflammatory response is also so severe that it starts contributing to the disease process. So usually in these conditions, steroids that can be used are oral prednisolone, which is given in a dose of 2 mg per kg, and this can be continued till up to 4 to 6 weeks on a daily basis, followed by tapering over 2 weeks. Use of steroids will reduce the risk of increased hypertension in case of tubercular meningitis. It will also help in reducing the constrictive pericarditis in case of pericardial effusion, and it can reduce the risk of airway obstruction in case of endobronchial tuberculosis. It is also indicated in miliary tuberculosis when there is a severe alveolar capillary block, which will manifest as hypoxia in case of, if it manifests as hypoxia in arterial blood gas analysis. In such cases, even in miliary tuberculosis, steroids can be used. So now we come on to question number 153. Which of the following statements are false about ostium secundum ASD? Fixed splitting of second heart sound, narrow splitting of second heart sound, left axis deviation in ECG, shunt murmur prominent, right axis deviation. So the correct answer to this question is narrow splitting of second heart sound, left axis deviation. So these are the false statements about ASD. Left axis deviation, shunt murmur prominent, so we'll talk a bit about ASD. So ASD is classified according to its embryonic origin. So accordingly, ASD can be either secundum ASD, which is seen in 75% of cases. It can be a primum ASD, which is seen in almost 20% of patients. It can be a sinus venosus ASD, which is seen in 5% of patients. It can also be a coronary sinus ASD, which is very rare. It could be a vestibular ASD, which is again extremely rare. Or there can be a patent foramen ovale. So with regard to ASD, in case of ASD, the tricuspid component of the first heart sound is loud, basically because the tricuspid valve leaflets are held apart till the end of the diastole. So the tricuspid component of the first heart sound is loud, but the classical hallmark of ASD is wide splitting of the second heart sound. So this basically results because of the overload of the right ventricle due to an increased venous return prolongs the time that is required for its emptying, resulting in a delayed P2. But at the same time, since the two atria are being linked because of the atrial septal defect, the inspiration does not produce any pressure changes, and hence a wide splitting of the second heart sound results. This ejection systolic murmur that is seen in ASD results due to the pulmonary, because of the flow across the pulmonary valve. The ejection systolic murmur originates from the pulmonary valve because of increased flow. This condition is more common in females. And the shunt murmur is absent in case of ASD, because the pressure differences is very less between the two atria. So the shunt murmur is absent. And in case there is a left axis deviation which is more than 30 degrees, it will indicate that there is a primum type of a ASD. So a left axis deviation of more than 30 degree indicates a primum type of ASD. So in case of ASD, you see that the tricuspid component of the first heart sound is loud. There is wide splitting of the second heart sound, which is the hallmark of ASD. The ejection systolic murmur results due to the increased flow across the pulmonary valve. There is no shunt murmur, mainly because of the reduced pressure difference between the two atria. This condition is more common in females, and any left axis deviation of more than 30 degrees indicates that it's a primum type of ASD.